Welcome to the Rehab and Performance Lab, the MedBridge podcast where we dive into the world of orthopedics and sports. We're here to unpack the big topics, offering you practical insights and valuable tips from some of the most inspiring professionals in our field. Don't forget to visit medbridge.com to get your continuing education credit for this episode, plus access bonus resources. Hey everyone, welcome to the podcast. I'm Phil Plisky, your host. I'm a professor, founder of Coaches Club, and author at philplisky.com, as well as a performance systems consultant in professional sports. Being a physical therapist, athletic trainer, and strength and conditioning coach, we like to come at this from multiple perspectives. We're going to give you the latest research, but more importantly, we want this to be practical and useful for you. I'm looking forward to our topic today of how to get patients the best outcome who are maybe a little bit more mobile. I'm joined by Dr. Jenna Gourlay, who is an expert in joint hypermobility and treatment. Welcome back to the podcast, Jenna.
Hey, Phil. Thanks for having me.
So for those of people who may not have listened to the previous podcast, which I highly recommend you do, could you give a little bit of a background about yourself?
Sure. I am a physical education teacher turned physical therapist. I currently work in an outpatient and sports clinic called Rehabilitation and Performance Institute, where I'm also our director of our orthopedic residency program. I see all kinds of things in the clinic, but predominantly it's youth athlete and also patients with hypermobility. In addition to the youth athlete, there is always younger brother, younger sister, all the way up to grandma, great-grandpa, and I absolutely love what I'm doing every day.
Oh, that's so fantastic. So can you bring us up to speed on what we talked about last time, in case someone hasn't listened, or maybe it's been a few months since they've listened, so they kind of have some grounding of where we're at.
Yeah, for sure. We talked a lot last time about what it is to be hypermobile, or what it is to have hypermobility or abnormal joint range of motion with your patients. So we talked how it's not necessarily as clear cut or like binary. So it's not either you have normal or typical joint mobility versus you are hypermobile. There's a lot more of a continuum in there. And we can't just use the Beighton criteria to help us determine where that person falls.
So I think that was a really important point that I don't want people to miss, because we think of hypermobile or people who are hypermobile and we just go Beighton, or we go the people that can do party tricks and, dislocate their shoulders, hyperextend their elbows, bend backwards, palm the floor. But it's more than that, isn't it? It's somewhat nuanced.
Yeah, it is those things, as you said, but if we think of it more as a spectrum or a continuum, we could kind of say like over on this side of the spectrum, it's people that are very stiff, that have low joint ranges of motion and don't move as well. Then maybe somebody that's a little bit stiff, normal or typical in the middle, those like textbook norms for range of motion, then somewhat hypermobile, and then on what you're talking about, more that like very hypermobile end of the spectrum, which might also include Ehlers-Danlos or some other things like that.
That's awesome. So what else do you want to bring people up to speed on?
Yeah, so the other thing that I wanted to talk to about is the fact that a lot of times we think, hypermobility might be a bad thing, but hypermobility doesn't necessarily lead to pain and dysfunction. Instead, it's often the fact that there's a lack of stability or a lack of motor control that actually leads to some sort of problem that would bring a patient into the clinic. So you don't need to fear hypermobility. Your patients don't need to fear hypermobility, but it is something we need to address from a motor control standpoint.
I think that's an interesting way of looking at it, in that, we know that there are certain people who actually are tighter, that maybe have a little bit more tone. And we really don't have much fear in treating those folks. And we might even be excited to treat those folks because we clearly know what they need to work on. And usually it is decreasing that tone and increasing their stability. But I like the way you're putting on a perspective on that is, people are just on a continuum of mobility. That tight person is on the same continuum as the hypermobile person. So we shouldn't have any, different apprehension or anything like that. It just maybe should change our treatment approach. And I think that's what we're here to talk about today, is once we identify that person that, is not on the tight end of the spectrum, that there may be a little bit more than one, their shoulder is a little bit more unstable in multiple directions, and they have a little bit more mobility in general, that treatment might need to change a little bit. So let's talk about maybe your evolution in treatment over time, meaning, so you probably didn't start off, identifying these people well, but even then, once you identified them, maybe treatment was a little hit or miss.
Yeah, for sure. So we talked last time about how in the beginning it was just difficult to figure out why a subset of patients was different from others. And I was getting into kind of that, somebody that is more mobile is in a little bit different of a bucket than somebody that might be typical. And when we take that to the treatment algorithm, I was trying to take the exact same treatment or treatment philosophies and apply it to that more hypermobile population. And I just wasn't getting the right results. It was either very unpredictable, where like maybe it would work very well in someone, or maybe it wouldn't work at all. Maybe it'd work one day, but not the other day. And it was taking so much longer than I was used to, especially when I was working with athletes and people that often didn't have a major injury or weren't post-op or anything like that, where I wouldn't think it was going to take this huge amount for a plan of care. It was taking that long.
Now, let's talk a little bit more about that concept of unpredictability, because I think that person who is a little bit more tight or has more tone, and maybe it's just my opinion, but I think those people are a little bit more predictable than people who are hypermobile. Can you speak to that?
Yeah, so when somebody was, maybe they were a little bit stiff joint-wise or a little bit more restricted in terms of range of motion, I felt like I could bring a manual solution directly to them, and then I could possibly do some sort of motor control retraining, and I would at least make some progress, and we would stay on this path, and it would be gradual but very predictable. We'd get a little bit more range of motion, they'd use it, it would get better. With the patients with hypermobility, they may present with, less range of motion. So they might not have full, let's say, active shoulder flexion, but then you look at them on the table and they have full passive, or maybe they still don't. With those people, again, I was bringing a manual solution to it. And I specifically remember this patient that I dry needled her back, and she felt phenomenal when she first got off the table. And I was like, great, that's exactly what I expected to happen. And then as the treatment session went on, she's like, I'm starting to get tighter. And I just remember getting an email later in the day that was like, this is the tightest I've ever felt. Like, I feel awful. And I was like, wait, we were just at a point where you said you felt phenomenal and now you don't. And that was not the only example that I could possibly give you about what I was experiencing with these patients, where maybe I made an improvement in the session, they went home and nothing stuck, or they got worse, or maybe I did 10 different things in the session and absolutely nothing worked.
Yeah, and you can be really frustrated by that. And sometimes you can just get frustrated with the person as well, because when it doesn't fit what normally works for you, I think sometimes my concept is I might blame the patient a little bit more, because, especially in that example that you just gave, you were feeling better. So what did you do? Right. And that's not really the case.
Yeah. And then the next visit, it was like, did you pick something super heavy up? Were you wearing your backpack on one shoulder? Like all these things. And she's like, I left the appointment with you and I hurt more. And I'm like, but it doesn't add up. And it does add up now, knowing what I know now. But at the time, yes, I was either putting it on the patient or putting it back on myself. So in other instances, I'd be like, maybe my manual skills aren't as good as I think they are, or maybe my clinical reasoning isn't bringing me to where I need to be, necessarily with each patient.
So you got there through a lot of different self-reflection, which is awesome. So what questions should clinicians be asking that might take them, down the road that you went, to be able to not only be able to help a certain subset of people, but to thrive and actually, dare I say, look forward to someone when they have these characteristics?
Yeah, so I think the questions that we need to ask first are to help us diagnose the patient. We talked a little bit about this, but I don't know that we got into all of the different nuances that could possibly be there. But the first question you need to be asking yourself is this person actually normal, or are they somewhat hypermobile, or are they very hypermobile? So the very hypermobile, I would say that's more of like your classical definition, right? That's the patients that are high on Byton, so 5 out of 9 plus, ones that maybe had dislocations or subluxations, ones that have a history of party tricks like you were talking about, or large joint ranges of motions, and maybe have those secondary characteristics. So they have flat feet or they have flexible feet and all those other things that go into it. But then that somewhat category is also very important. So you want to ask yourself, is this person somewhat hypermobile? Is there some clues that would help put them in a different bucket than normal? So that might look like they're not high on the Byton criteria. Maybe they only have 2 or 3 or 4 out of 9 versus that higher. Maybe they, only have a couple of those secondary characteristics and not a ton. And maybe they do have some mobility elsewhere that's greater than normal, or maybe they don't. So how does one side compare to the other? And I think that can definitely help us as we're trying to figure out how to treat these populations. First, we need to know who we're treating and that we're treating the right person.
So we've got to get them in that category. And I can't really harp on this enough. I even look at myself. If you were to do a Byton on me, I think I might have two positive points. My knees hyperextend about 15, maybe 20 degrees. I don't know, but that's it. But if you look at my overall mobility, it's as a I won't even say my age. Let's go upper middle age. And if you look at my overall mobility and movement, it's really good, particularly for my age. And so talk to me about how someone like myself fits on that continuum, and how important is it to note that with the treatment?
Yeah, so we could look at it 2 different ways. So one, we could say that you're more maybe in that somewhat hypermobile category, and we could ask you like, okay, so you have that hyperextension at your knees. Have you had a history of any kind of subluxation or dislocation? Do you have a lot of range of motion elsewhere? So the Byton only looks at, those 9 things, but do you have a lot of shoulder motion, like greater arc than what's normal? Do you have a lot of like jaw opening? There's so many other areas that you can look at. And then other questions like, do you bruise easy? Are you super sensitive from, sensory and touch and things like that? Do you have a lot of flexibility at your feet? Do you sit in all kinds of weird positions according to other people because you just love being at end range? Do you have trouble sitting still? Like those kind of things start to push us more towards that somewhat hypermobile, which if we address it with the treatment that we apply, you would get better faster. The other thing that you can consider too is, was somebody historically hypermobile and now they're not because maybe they had surgery, they had a previous injury, or just as we all age, we do tend to get a little bit stiffer. So, was there a lot of clues in your past that now we can kind of bring forward?
Oh, that's fantastic. I love all those questions because, I even think probably some of our listeners right now are going, wow, that's me. And I didn't even fully realize it. And those questions are hard to really kind of parse out in the research. They're there, but you really have to put a lot of different pieces together and put it with experience treating a large number of patients with increased mobility to give that picture that you just gave. So I really appreciate it. So, how do we look at, maybe a patient's response or different activities that will, kind of aggravate or improve, a patient, if we can kind of, again, stay on that history kind of concept, what are those types of things that we should be looking for?
So are we looking for in like their everyday life, or more like from a treatment?
More in an everyday life type of thing.
Yeah, so these are the people that may have pain or what they consider tightness in an area, but they aren't necessarily tight. It's your gymnast that comes in with an active straight leg raise of 120 degrees and says, can you stretch my hamstrings? They're so tight. So we have that. We also have people that sometimes get more misuse or overuse injuries a little bit quicker than you'd expect, or that every time they start basketball, now they're presenting with, pain in their shins, or, maybe pain changes. So like you might have a patient in front of you that was coming in for neck pain and now their right shoulder hurts, but last week their left shoulder hurt, and the week
And
before
then their left knee hurts sometimes too.
Yes. So you're starting to see that. Or it might be somebody, I have a lot of parents of children that have hypermobility that tell me, my kid is athletic, but they're also very uncoordinated, or, I can hear them coming a mile away because they hit the ground so hard, or they seem like they're running through mud. Like these little things start to clue you in. And it's not necessarily completely research based. There's things in the research that can explain all of these things, but there's not necessarily a study out there that says, a kid that runs loudly or like stomps on the ground when they walk, they're hypermobile. And that's not what I'm saying either. But when I start to see a lot of these things start adding up, I'm like, what is going on with their mobility?
All right. So if we've identified, I think we've done a really good job of identifying them, putting them in on that spectrum, if you will. What does the research tell us? How can the research inform our treatment?
Right. So there's a lot of good research. So one, physical therapy is an awesome outlet for these patients. So physical therapy in general, there's a lot of different studies out there, but physical therapy in general, people did better. So whether it was weight training, whether it was isometrics, is a lot of research that is a very good intervention for these patients. Even like mindfulness and meditation and those sort of things. But time and time again, it comes to physical therapy can help with pain, with dysfunction, and even with some of the injuries that patients with hypermobility experience.
That's awesome. So what are the characteristics of the person in the research that inform our practices for treatment? Like, how can we, as you say, there's physical therapy, there's all these different things, but it's probably not very specific. But how can we take the research of what we know the characteristics of a hypermobile to be to maybe start considering what our treatments should look like?
Yes. So I look at it in phases and always trying to help ease patients with hypermobility into it. Every patient is going to be at a different level. And this becomes even more important if someone does have hypermobility, because we talked last time about if someone is hypermobile, they tend to have decreased proprioception. So they don't quite know where they are in space as much. They will also have protective tone often. So they might have hypertonicity where their prime movers are doing things that their stabilizers should do. And we also have to consider load. So if they don't have the baseline stability that they need, when we start getting into treatment, are we starting at an appropriate level for them? And the way that I look at it is definitely in a phases. Like phase 1 is the easiest. That's where we start. And then we want to progress them throughout that.
All right. So let's get this into the clinic. Let's translate this from research, which, kind of sounds like there's way more than I would have anticipated out there. But let's get this to practical, right. How do we do that?
Okay, so I would say that the first thing that we need to do for these patients is to improve tone. And so when I say improve tone, with a lot of patients, it is going to be decreasing tone. So decreasing hypertonicity or protective tone. Maybe they have a lot of tone in their neck because they're trying to protect a shoulder. But these kind of things might be like PNF works really well, and there's research to support that. Meditation or mindfulness to help decrease that tone. Breathing especially. And then there might be other things that would prime this person for improving motor control. So that might be something like taping that individual or using compression or using soft tissue. Soft tissue is definitely a good option, but we kind of said before, sometimes it is unpredictable. Sometimes a patient feels awesome right after you do something, but if we're not then following it up with the right exercise from a motor control standpoint or a stability standpoint, sometimes we give them the motion back that the tone was trying to protect them from, and we don't give them that stability to help them protect themselves.
So what I'm hearing is a very consistent theme in the things that you're describing. You are, if the person indeed does have increased tone somewhere, you're decreasing that tone through maybe a much more hands-off approach, or actually what I would almost even kind of consider a neurological approach where they're doing it through their breathing, they're doing it through their awareness, they're doing it with a muscle contraction to decrease tone, not a muscle inhibition to decrease tone through a manual technique. Is that fair?
Yeah, that makes a lot of sense. And with it too, like, I mean, we're not going to say that we never do those other manual techniques, but there are sometimes better options. And sometimes you need to know your patient a little bit better first before you bring some of those. I wouldn't say that they're aggressive for the normal population, but maybe a little bit more aggressive for somebody with hypermobility.
Yeah, that makes a ton of sense. So if we look at those folks need this detonification maybe in a different way. I know it's kind of a big word, but to decrease the tone, how does that work for decreasing their pain, or how do we address their pain?
So that is where, like, sometimes you might opt to do some like gentle soft tissue or things like that. But there have been even more instances where bringing a stability solution to that pain or around that pain often can help decrease it. So in the case of, let's say a patient that has like a lot of neck pain and it especially hurts to rotate their head, but you lie them down on the table, maybe you give them a little bit of like postural support with the table, you take away gravity, and all of a sudden they can rotate it a lot better and with less pain. Well, okay, we got to give them something to help them against gravity. Maybe we actually need to give their shoulder a little bit more stability so that neck or the upper traps, those like more prime movers, can relax a little bit, and we get some more of those stabilizers to get on board and do what they're supposed to do.
That makes sense. Take me through a patient's kind of stepwise. You mentioned stages and things like that, but I imagine this involves a lot of education and how do you educate them on what they're feeling, and like, again, a lot of these folks, it's somewhat comical, I think, when they come in and they're like, oh, my hamstrings are so tight, and they go and they're like, look, when I have to like take like 2 or 3 minutes to be able to beyond palm the floor, and you're like, it's probably not tightness there.
Yes. So it's definitely an education. That's why sometimes it's harder in the beginning, because this might be somebody that has never been told before that you don't need to stretch. And when they're used to doing a stretch or getting to end range just to feel something, to stop somebody from doing that can be really tough. And I like to use the analogy of a mosquito bite. So if I have a mosquito bite and it's itchy and I scratch it, it feels awesome in the moment. It's like, oh, I'm scratching an itch, but like it makes it even more inflamed and even more itchy, and it gets even more and more annoying. And that's sometimes what can happen with patients with hypermobility. It's like the stretch feels good in the moment because they're getting to end range, because they have lower proprioception. So now, they're feeling something in, whether it's the muscle, whether it's the nerve, whether it's the joint, and their body just kind of is like, ooh, I like this. And then they do it, but it's like after the fact, now they've even stretched a little bit further into where they don't have motor control, and it can actually make it worse. So there's definitely a good amount of education there to get patients to stop stretching or overstretching, and then also to stop self-manipulating.
That self-manipulation point is a very big deal, because you get that stretch. I've never heard the mosquito bite analogy, but that really does. I mean, that's literally spot on, because it feels good to them initially, but it is just really actually just irritating them, and then they feel worse. And the same thing with self-manipulation. How do you talk about that with them?
So, I do talk about it, but then I always, if I can, try to show it to them. So there are a lot of instances where if they have, like, let's say they feel a lot of tightness when they go down and they do try to palm the floor, if I can give them, whether it's like squeezing a ball or maybe it's just a farmer's carry for a little while, and give them a little bit more stability, core stabilization, and then have them do it and they don't feel as tight, then you can get that aha moment of like, let's pause here for a second, because we didn't stretch you, right? And they're like, no, we didn't stretch. And I'm like, and you do feel less tight? And they're like, yeah, I do feel less tight. And it's like that first feeling of like putting those pieces together. Because I could sit here and, you can tell me stop self-manipulating all you want. But if that is the only thing that I have found that
It's
makes me
relief.
feel better.
Yeah.
Like I want to do it. But if you can instead replace it with something, that's way more powerful.
I think that's probably not even beyond just working with patients with increased mobility. That's probably a good, rule of thumb with all of our patients. To stop doing something is a lot harder than to replace doing something. So I think that's a big take-home message. So it seems to me that what you're describing, though, so we have this education component, but we have this load component. How do you know, how do you progress and choose where someone, because I could imagine given someone, I don't think we probably load patients with increased mobility enough, but I imagine it also can be pretty easy to overload them as well as underload them. So how do you get there?
And I know, like you're saying, sometimes we underload them. So I don't want to say we're necessarily overloading them, but we may be loading them too early or loading them inappropriately. So one of the best entryways into that are isometrics. Isometrics we're in, that we start maybe mid-range. We're not getting into those far ranges of motion. We're nice and controlled, and they're in charge of what they're doing. So that's an easy entry point. The other easy entry point is often closed chain exercises versus open chain exercises. So when you get somebody, let's say in quadruped, they now have a ton of information from the floor. They have a ton of information from gravity. And you can even, a lot of times I'll throw, an ankle weight or tell them to throw a bag of rice on their back to give them feedback of where they are in space. So we can get closed chain, and we can also give external cues to help them with that proprioception piece, helping them know where they are in space. Like, I want you to know that you are in a ton of lumbar lordosis right now when you don't think you are.
That's awesome. So really it is about gaining that awareness, and that awareness comes through mid-range isometrics first, in external feedback, so that they can really know where they are in space, and then start from there. If that's tolerated well, then we can progress. All right. So one of the frameworks you have is the 4 E's. Can you talk to us about what that is and how you apply it?
Yeah, so that is the 4 E's is to first educate. So we talked a little bit about that in terms of, getting them on board with how they're caring for themselves, and also getting them on board with their positioning. So getting out of that lumbar lordosis, getting out of them locking out into 15 degrees of knee hyperextension or 15 degrees of elbow extension when they're in a push-up position or something like that. The next E is empower. So this is a group of people that, as of right now, it's taking them sometimes up to 7 years to get a diagnosis or to get people to figure out that it is somewhat of hypermobility playing a role in their dysfunction or their pain. So we want to empower them, not let them be afraid of the fact that they're hypermobile, because again, it's not hypermobility that's the problem. It's the lack of motor control and the lack of stabilization. So empowering them is a big thing. We get into that.
They have to have a trust issue with the medical system and things not working, and having I would imagine they have a lot of experiences with very short-term relief too. That they go in, they get a manipulation, they feel better for a few hours, and the pain comes right back. And they almost get into probably some chronic pain as well because of it.
But it's like sometimes people put them in the category of chronic pain, and they act like there's not necessarily an anatomical or a pathological reasoning.
So they're going to talk them. They're going to neuroscience pain educate them through this and say, you know what, your alarm system is going off in the wrong way, and that's really not. That's actually probably a pretty harmful approach for these folks.
Yeah, because we need these people. We need these people to use weights and load, because that is what's going to get them that stabilization, that proprioception, and get everything working better together. So again, we are looking at first educating, then empowering them, and then we want to look at external cues. This is not the type of population that you want to say, do you feel it in your glutes, or do you feel your core kick? It's hard for them to feel things, or if they are feeling things, sometimes it's not exactly what they should be. So the more things from external that you can use, whether it's, feedback, like I said, from like an ankle weight or something from that taping techniques that we talked about, from the ground, if you're in closed chain, anything you can do, like giving them a little bit of input, pushing them like almost like R&T, pushing them into the problem a little bit more, that all helps them with that motor learning.
That's awesome.
And then that last E is easing into everything. We don't want to jump into something with a patient. We want to make sure that they have decent muscle tone, or they have decent pain, like decreasing their pain. We want to make sure that they have the correct load, that they have the right amount of proprioception. And then we want to make sure that we're picking the right things for them. So, we talked about like closed chain is a really good idea. What's not a good idea, and what surprised me initially, was that they don't do great with bands. So like think like TheraBands, right? So like when I think like low level activity or low level exercise, I'm like, TheraBand, let's grab a yellow or an orange TheraBand and let's give a little bit of resistance, but not too much. And the TheraBand is often harder for them than a little bit of weight or their body weight, because it's unpredictable and the amount of resistance changes throughout them using it. So let's use, just an shoulder external rotation with the band. That resistance is not the same throughout the entire part of the joint. And that might be okay for some people, but for somebody that doesn't have that good sense of awareness, that becomes extra challenging. And so we might bring an inappropriate thing that we think is really good, but for them, it's actually a higher load than what you typically would think, like a kettlebell.
When you say it that way, there's so many patients that I see who come from other providers, and let's say they're a high school athlete, overhead athlete, tennis player or whatever.
Uh-huh.
You give them, I ask, it's my number one question, what'd you do before?
Uh-huh.
Almost exclusively, I hear that they did bands and throwers 10 and things like that. And they either didn't get better or they got worse. And so, it's kind of hard sometimes to get them to step back and say, hey, we're going to do isometrics here, and we're going to really focus on your form. We're going to really focus on you having good body awareness and good position. And maybe we'll start it at your side. And then as you progress, we're going to continue. My normal treatment would have been, I'm going to continue and go, all right, I started with isometrics. Now I'm going to go to bands.
Uh-huh.
In reality, that's not what actually works. I find that I need to go to maybe a 90-90 position in a neutral but an elevated position, and now watch that upper trap is kicking on, and it's just like a whole new it's a brand new exercise to them. It's a whole new world, and that can be an interesting challenge, because you think you're staying at isometrics. Sometimes I'll be there for weeks.
Yeah, weeks. And I mean, you can do a lot with isometrics. So we're thinking, the typical like shoulder isometrics, like you're standing at the wall and pushing in. You can also push in and move the trunk. So like I might push into external rotation, and now I rotate my trunk outward, and now suddenly my shoulder, instead of being in, a 0 degree of external rotation, now all of a sudden I'm in 45, but I moved my trunk on my shoulder versus my shoulder on my trunk. And things like that can often help them tolerate things better.
You're almost tricking the neurological system there, aren't you? Because when they've gone to exercise before, they've had pain. And so their body, if we go back to, pain neuroscience education, their body is going to respond with pain, even if the stimulus isn't necessarily damaging. It's going to respond with the pain signal, because before they did too much or it was too much load. Now, I frequently see patients with this that, you talk about position, you talk about closed chain. I find like a lot of patients don't even tolerate the hands and knees or the quadruped position very well on their wrists. Is that something you find, and what does that look like?
Yeah, so I think one, yes, you can definitely go on to fists. So you can get that wrist in a neutral position and you can work from there. However, I think sometimes it's just being unfamiliar with the sensation. Like it's not necessarily a bad thing that they're feeling. It's just different. So we might try a little bit on the hands and then go up onto to fists and then go back down onto hands, because there is a little bit of a bonus in terms of being able to like spread the palms out to get a little bit more feedback and a little bit more input and to increase the base of support too. So I don't want to say that, oh, it hurts, let's get away from it, let's never go back to it. Because a lot of times it is something that's just a little bit unfamiliar to them if they haven't done it. Now, if it is consistently a point of pain, or if it is somebody that maybe has more Ehlers-Danlos presentation, that might be somebody that, okay, we do have to go on fists, or we need to put dumbbells on the ground so that they can grip the dumbbells, because there is a lot of good that can happen through your grip.
That's probably, I'd probably say my most common, accommodation would have been to go to that fist position. Wrist is nice and neutral, but that dumbbell position can be super powerful, because what you're talking about is that input, you remember the homunculus, right? And, it's how big our hand imprint is on our brain. If we can get that sensation, we talked about, these are the folks that don't know where they are. So, going to fists, we've somewhat removed that know where you are sensation. And so if we can go to dumbbells, we've got that full normal grip.
Yes.
It can be in a more neutral wrist position. So if I'm going to accommodate because they truly just can't tolerate the hands and knees position, boy, that dumbbell position sounds like a much better option. Yeah,
because we also know that when you do grip something, like you get a co-contraction at your shoulder and at your rotator cuff. So if we can get them to, if they are on their hands, push into the floor, or if they are gripping the dumbbells to squeeze it harder, sometimes we can just get that humeral head better in the joint and more central, and it feels better for the patient. So it is a cool go-to.
That makes a ton of sense. All right. So we've talked about identifying these folks. We've talked about how to educate them. We've talked about the general principles of exercise and what to do. Let's go right into some case studies, some hypothetical examples of what it looks like to work with a patient.
Okay. So I'll change enough of the patient details that they'll be unidentifiable. But one that comes to mind so clearly is a patient that actually came to me as a second resort after having had some previous physical therapy that was dealing with a lot of recurrent shoulder subluxation. So the tennis player, and she continually subluxed her shoulder. Sometimes, every practice, sometimes, every other practice, but it was frequent. And she came in and we looked at everything. We asked her what she had been doing. They had tried a lot of band activities. They had done some dry needling. They had done a lot of things. And she said that she got a little bit better, but not a ton better. And now the cool thing about this patient is this patient, even though she had a good amount of subluxations and things happening at her shoulder, in terms of biting, she actually wasn't really high on it. She had bilateral knee hyperextension, but everything else was pretty good. So it was only a 2 out of 9. However, when we looked at her shoulders, she had a huge total arc of motion on both sides. So not just the right arm, which she was right-handed, from being an upper extremity athlete, but on the opposite side too. So we saw multi-directional instability in the shoulders and a ton of range of motion. These are the people that can do like the Apley scratch test and like practically grab their opposite wrist versus their fingers together. She had.
But if you were to ask her to palm the floor necessarily,
she couldn't even touch her toes. So you would look at.
So I think that throws people off, doesn't it? Because again, if we remember one hallmark characteristic of the Beighton criteria, it's palm the floor, and if someone can't touch their toes, if you only had that one piece of data, you would say they're not hypermobile.
Right. You would assume that they're fine. Like they're typical. They're typical, but she wasn't, because she had subluxations. She had the increased range of motion in both her shoulders. She did have both knees of hyperextension. And then she did, complain about low back pain here and there. And she had arches in her shoes because, she would overpronate. And she was the type that I was like, what's this bruise from? I don't know. What's this bruise from? And just like another quality is sometimes people have very soft, silky skin. It's just like a different kind of from like a connective tissue standpoint. But so she had these other things outside of Beighton. And I also had the benefit of knowing what didn't work for her in her previous bout of physical therapy. So for her, what it looked like, we started I wanted to start with some shoulder packing, scapular packing, or like getting, a good kind of stability at the shoulder blade. But she literally had no idea where that shoulder was. Like, I'd be like, "Are you packed?" And she'd be like, "Yes," but her shoulder would be like maybe a half a centimeter from her ear. I'm like, "Well, that's not packed." Or I would be like, "Okay, bring it down." And all of a sudden, like, her entire trunk would side bend, and she'd be like, "Okay, I'm there now." And I'm like, "We need something in between." So she actually did really well putting her in side lying and working on a little bit of PNF for the shoulder blades, just to kind of help her figure out, okay, this is the top of the range, this is the bottom of the range, like find the middle. We worked there for a while, and then we went onto her.
I got to pause there for a second, because I think side lying is maybe an underappreciated transition in developmental postures. We may do it in neuro rehab, but we don't necessarily think about it in sports and orthopedic rehabilitation, where if someone can't do something supine, prone, or quadruped, maybe that side lying just gives, again, that different input, that different feedback that these folks need.
Yeah. So, once we got her in side lying and I was able to, get a hand on like the top of her shoulder and kind of like underneath her shoulder blade, now she feels the table on one side. She feels both my hands kind of on both aspects of her scapula. And now she really doesn't have to think all that much except for how she's moving. And then she could start to find the middle. So once we had it there, then we went and we worked on it for a little while in supine. And again, this is like, I'm telling you this, but I think the first visit was only side lying, and then she had to work on it at home. And the second visit, we did get to supine, and she was able to get it, but we didn't go to weight from there. We actually just went to squeezing a towel. So like find where that good position is, just squeeze the towel, and then that was that. And then by the time she came back again, I think it was maybe like third or fourth visit, she had to the point where her pain was down, and we were able to now get her into quadruped. The other thing that she responded so good to was rotator cuff sling taping. So it's something that's easy to find on YouTube, but it's just tape that you're putting on the side of the shoulder, kind of from like deltoid tuberosity up to the acromion on both sides, like a teardrop. And it just helps facilitate the rotator cuff. For her, it just helped her get a little more input in terms of where she was. And it immediately decreased a lot of the tone around her shoulder, because all of a sudden she was like, "Oh, I kind of know where I am."
That's awesome. So now as we go through that, then so I think we've kind of gone through a couple different phases of the rehab. Where does it go from there?
Yeah, so we went from being in quadruped, like both arms on the ground. We started doing almost like a bird dog. So now she's going into a little bit of open chain, and we're doing everything on both sides because we get benefit of being on the ground on one side. We also are challenging it when we're raising it on the other side. But once we got comfortable there, now we're going to go up into a stacked spine position. So we're going to get her up into kneeling or into standing. The first thing we did there was just holds with a weight. So I gave her a weight, and I just wanted to hold it. I just wanted her to hold it in front of her. And we did revert back a little bit. So like now I have her kneeling, and I hand her this weight, and she's done so good at figuring out where her shoulder blade is in space. And the second she picks up the weight in kneeling, all of a sudden she's doing a shoulder shrug again. And I'm like, "Do you know where your shoulders are?" And she's like, "I think I'm good." And it was like, okay, we gotta give you some more feedback. We gotta get you to feel what you're experiencing. And then we were able to go from that, those holds, to then more of like a farmer's carry, where again, she's stable and she's not moving her arms while she's walking, but now we're moving her legs. And then we went back to doing more open chain, where we got into a little bit of like chops and lifts and things like that.
That's awesome. I think it really says to me that I find that these folks tend to want to be very active. They tend to want to engage in fitness. They tend to want to engage in their sport and I recognize that's a gross generalization, but it makes a whole lot of sense of why they have so much pain and random pain when they do, because they use so many different compensatory patterns as soon as their load increases too much or that they fatigue.
Yeah.
And when and that's what sport and fitness is load and fatigue. And so I think we're kind of touching on why it's so hard for them.
Yeah. And they also they're getting the same coaching and instruction. If they're in a sport, as kids that are typically mobile, and they have to worry about, an extra like 20 degrees of motion that the other kids don't. And if they don't have a coach that understands that, then they're going to do some pretty, again, compensatory things to achieve what they need to achieve, but like at what cost?
Right. Absolutely. Do you have an example of maybe someone who, I really like that we've identified for the audience that this is not someone who is just necessarily really high on biting. Do you have someone as in mind that we could talk about, that how the treatment is different if we're really farther along in that spectrum, meaning we might be close to Ehlers-Danlos, or we at least are very high on the Beighton criteria?
Yes. So if we're very high on the Beighton criteria, then it is going to be slower, and depending on somebody's background too. Like if you have somebody that's been lifting and has some experience, it might not take as long, but there are a good amount of people that either haven't done something in a while or are just fearful to do it. So there is going to be a lot more manual cueing and a lot more, my hand's going to rest on their shoulder at times, or we're going to stay out of like extreme ranges of motion. But those people, we're going to progress very slowly. We're going to stay pretty much all mid-range in terms of like where we are with whatever joint we're working on. And we are going to go mostly isometric and mostly body weight until there is no pain and until they feel really confident. Because one of the things that I'll ask often is like, does it hurt? And with this population, sometimes things don't hurt, but they feel weird. And you need to help them be able to verbalize that. I'm like, I want to know if this exercise feels off in any way. Like, if you can't explain it, that's fine. Just tell me this feels weird. Because I think what we're getting at when they say that is, I feel unsafe or I feel apprehensive, in which case I know I have to back off.
Oh, that makes a lot of sense. That's probably something maybe we just kind of plow through as practitioners because we're asking pain, and there's interpretation and sensation of pain is different, and they don't say that's pain.
Right.
That's a very powerful statement right there, because they don't feel it the same way, but guess what? They feel it later.
Yes.
When they stop that night, or on the car ride home or whatever, like, wow, everything just seized up and I'm really painful.
Because we're talking about what I try to do, but it's even more so what I try not to do. I try to go slower than I initially want to, because it's way easier to progress someone maybe even very slowly versus I push too far and now everything is like ramped up, and now the tone is back and the apprehension is back, and now we have to kind of get all that to calm down again before we get back to this higher level thing. So my main goal is to, if you watch a session with me, it's annoying how much I'm asking for feedback from these patients. Like, do you feel pain? Does it feel weird? Does it pinch? That's another one. So like sometimes when there's not good motor control, they might get a pinch in the hip if you're working on the hip, or they might get a pinch in like the shoulder, pec region, and they might perceive that as, oh, it's kind of like a stretch, but a pinch and a stretch are different. And again, helping them differentiate that can be the difference between a really effective treatment and maybe sending them off with something that's a little too high.
Oh, that makes a ton of sense. We've gone through so much good information. How can you summarize this for everyone at home? What are those 3 actionable takeaways that people can put into practice immediately?
Okay, actionable takeaways. So the first one would have to be to find what level your patient is at. So we talked about how to, determine whether someone's hypermobile or not. We need to also determine, like, where should I be starting with this patient? Should I be starting with breathing? Should I be staying with, breathing and some isometrics, or can I bring them up? And then maybe even just subtract a little bit off of that, just as you get going. The next thing is we have to educate these patients. These are patients that feel a lot of different things, are usually very in tune with their body. And if we don't explain why, or at least give them some insight into what's happening with their body, it can be scary, and it can also feel like this is never going to go away. So making sure that we educate them really well. And then the last thing, and I don't know that we got into it too much, is I want to give all of these patients a list of go-tos. So I say that because
explain that a little bit more.
Yeah. So every patient that I have that has hypermobility, I am trying to find those 2 to 3 exercises that they can do that brings their pain down or that brings their dysfunction down pretty quickly. And this usually comes out as you get the pain down in the session. But usually there are a few things that somebody can do that makes it feel all better. So in that tennis player that had those subluxations, for example, once we got her good, if she felt anything off, maybe it was fatigue, maybe it was pain, she knew that she had to go do her farmer's carry. And with another patient, if their hip starts, they have like a little bit of pain, like hip flexor region. If they know that starts, like theirs might be, you got to do your bear crawls. But I want each patient to have a few different management strategies so that they can take some of the control back, because that's sometimes what this feels like for them, is like, I get pain and then it flares up and I don't know what to do. So if they have at least 3 things to change the pain or change the dysfunction, it's incredibly empowering.
That's incredible advice because in particular, like I think we should be teaching all of our patients how to self-manage and how to deal with flare-ups and not expect, perfection all the time. But in this patient population in particular, they will have more opportunities for those 2 or 3 go-to things that can basically bring stability back to their system is usually one of the ways I characterize that.
Yeah.
Well, this is awesome. So, we're running out of time here, but I would like to wrap things up, with a question. If you were to go back and speak to yourself as a new professional, what advice would you give?
When it comes to treating and treating patients with hypermobility, is that what you're saying?
Sure. Yep.
Okay. If I could go back and tell myself something, it would be to go slow and to test and retest more than you think you should. Because if you test and retest, often you'll catch on to the fact that something might be a little bit too hard for them. So if I'm working on somebody's, shoulder pain and they don't have good shoulder flexion, but we do a stabilization exercise and we get 10 more degrees, but then we go to another exercise and we go down 10 degrees, I at least know which exercise was the good one. So especially as you're getting into this, you're not used to it, or maybe it's a little bit different than what you're used to. You can do a lot of good by test and retest, and you'll actually be more efficient, even though sometimes it seems like it's taking longer.
So pick that movement pattern or joint range of motion that is basically your comparable sign. And you have to investigate, because you think your traditional stability exercise, which works 95% of the time, it just sometimes doesn't in this population.
Exactly.
Oh, that's awesome. Well, fantastic. Well, as we end here, how can people connect with you?
Yeah, sure. People can email me at jennagourlay@gmail.com. That's like the best way to get in touch with me. I love talking about patients with hypermobility. I love talking about physical therapy in general, but specifically patients with hypermobility. And I love helping people when they're like first on their journey of like figuring things out. So I would love you to reach out, send me questions and that sort of thing.
Oh, fantastic. I love to hear that. That's so awesome. If you'd like to connect with me, you can find information on what I'm up to, what I'm learning at philplisky.com. You can always contact me through there. Well, Jenna, thank you so much for being here and providing so much good information to be able to help our patients with a little bit of increased mobility.
Yeah, this was fun. Thanks for having me.
Fantastic. Well, until next time, let's keep building the future of rehabilitation and performance together. Thank you for tuning into this episode of Rehab and Performance Lab by MedBridge. Please be sure to subscribe and listen to more of our episodes on Spotify or your favorite podcast platform and at medbridge.com. If you're listening outside of the MedBridge catalog and would like to access the bonus resources and receive continuing education credit, simply log into your MedBridge account and search for this episode to find the accreditation details. Rehab and Performance Lab also listens to you. If there's a particular clinician that you'd like to hear from, or if you have a clinical question or a challenge that you would like to see addressed on this podcast, please let us know by leaving a comment on our Instagram posts or by emailing podcast@medbridge.com. See you next time.